Good morning, everyone. I welcome you to the class of medicine today. I know it's Sunday and we are a little lazy today, but guys, if we want to achieve the success, trust me, we have to overcome with our laziness and then we have to start doing our hard work and smart work. See, guys, anything can be achieved. The only thing you need is the maximum willpower and a positive attitude and a positive thinking. And I'm pretty sure that we all medicos have that this ability of having a positive attitude and a good and a great willpower, which is going to bring us a glorious success. So in today's class, what we are going to discuss is about the important topics as we have discussed in the last classes that I promised you that we are going to discuss some of the theory part now that I will discuss some important topics from cardiology, respiratory, and I will try to cover other medicine topics or the subtopics according to the time, right? So, guys, can we start today's topic? So, the first very important topic we will take it from cardiology, and from cardiology, the most important topic, I think, the basic topic basically is atherosclerosis. Because if we know about the atherosclerosis, we can actually get to know about the further diseases like myocardial infarction or ischemic heart diseases. So let's talk about the important topic in the cardiology, that is atherosclerosis. See, I want to make this very clear that this is a quick review of the topics that we are going to discuss. It's not a detailed video, so my concern is to get you introduced with the important topics, right? So let's talk about the first very important topic, that is atherosclerosis. Now, what is atherosclerosis, guys? Understand the concept. Now, by definition, what is happening? There is a accumulation of the fats and lipids in the walls of the blood vessels. So, first of all, you have to understand there is accumulation of fats and lipids in the walls of blood vessels. Now, when I am writing that there is accumulation of fats and lipids, understand this concept. So there is a collection of fat and lipids where beta in the walls of blood vessels. So होना क्या start हो जाता है यहाँ पे दोस्त? देखो, I am just going to draw a picture over here. Suppose this is a normal coronary artery or normal vessel. Let's take it as a vessel, right? So this is a normal vessel. What is happening over here? That there is a normal blood flow. From here the blood is coming and here the blood is going out. So blood is going easily. There is no obstruction in this blood flow, and blood flow can reach to the tissues properly without any obstructions. But what now start happening? This is a vessel which I am going to draw. This is a vessel, right? This was the normal vessel. This was the normal vessel. But what I have told you that this is a wall. Now you see over here that this is a wall over here, and in this wall there is a accumulation of the fats and the lipids over here. Now see this concept over here. Now this yellow color is what beta? This yellow color is basically fats and lipids. So now compare both the pictures. Picture number one, here there was a free flow of the blood, but now there is a accumulation of the fat and the lipid. What will happen? The flow or the pressure even will reduce because of this obstruction caused by this extra fat or lipids in the blood vessel, right? Now in severe cases it is going to reduce the flow. Over here there is a reduction in the blood flow, but in severe cases where all the symptoms like myocardial infarction or anything occurs, what happens over here? There is totally occlusion or totally obstruction of the blood flow. ये सारे का सारा क्या हुआ? Blood flow बनना start हो गया. And sometimes what happens, my dear friend, this vessel ruptures, this fat starts coming down into the vessel and it starts forming the plaque or it starts forming the thrombus formation also, right? So now what will happen? This blood which was going forward won't be able to reach to the tissues. Particularly if I am talking about the coronary arteries, the myocytes or the muscles of the heart won't receive adequate amount of oxygen, and hence patient will land up into myocardial ischemia. We will discuss in detail. This was the basic fundamental that you need to understand, right? So why atherosclerosis is the important topic I am telling you, because it is the major risk factor for coronary artery disease. It is the major risk factor for coronary artery disease, to understand this point. And what is the major risk factor for atherosclerosis? Risk factor, most common or the major risk factor for atherosclerosis is, yes, first of all, smoking. धूम्रपान सबसे हानिकारक है, right? A person is smoking and he is at a risk of developing the fats or lipids in the vessels of the blood walls. Got my point? Another risk factors include like hypertension. This was one. Other risk factors include like hypertension, diabetes, dyslipidemia, right? Now understand the concept. In dyslipidemia, they ask what are the lipids which are responsible to cause atherosclerosis. So you should be very clear that if there is increase in LDL and increase in very low density lipids, this is the risk factor. Increase of triglycerides, and very important, decreased HDL, high density lipoproteins, is a risk factor. Underline this thing. Decreased high density lipoproteins is another risk factors, right? Apart from this, there is a very important risk factor, and multiple choice questions has been asked that which increased levels, homocysteine levels, which levels beta? Homocysteine levels is another risk factor for atherosclerosis. Homocysteine levels is another risk factors. Apart from this, increase in CRP, increase of fibrinogen, is a risk factor, right? Then hyperinsulinemia, right? These are the risk factor. Then remember in some I think day before yesterday when we were discussing about MCQ part, the very first MCQ was there that there was a 30-year or 27-year or something like this thing. Male patient presented to the emergency with the central crushing chest pain. He started having this when he was dancing in a bachelor's party. ECG was done and it shows ST elevation, right? In lead 1 to AVL or maybe somewhere else. I don't remember exactly, but that patient had ST elevation MI. And there I explained you one thing. Can you please tell me what was that one thing which I explained you over there? Hanji, can you please tell me what was that one thing? That one thing was cocaine abuse, and I told you the mechanism of cocaine, how cocaine can cause basically MI. So cocaine abuse, or heroin abuse, these are the some of the causes, guys, which can actually lead to atherosclerosis or increase in the accumulation of fats or lipids, right? And the important one there is, this is also a risk factor, that a positive family history of cardiovascular diseases or cardio CAD, right? This is another risk factors. So what are the clinical features, guys? What are the clinical features of a patient with atherosclerosis? So first of all, the clinical feature, let us look at this picture. Now in this picture, there was a pretty normal flow. In this picture, there was a reduced blood flow. And in this third diagram, there was totally obstruction or total occlusion of the blood flow. Now guys, let's talk about this picture. If there is a reduced blood flow, is the patient going to receive adequate amount of oxygenated blood? Obviously not. So if it is not going to receive adequate amount of oxygenated, what will happen? The demand and the supply. There will be a mismatch between the demand and the supply, right? And due to this, the patient will have, less oxygen, and patient will develop dyspnea. So patient is going to develop dyspnea, right? So due to this, the patient will have decreased exercise tolerance, decreased exercise tolerance, right? Patient can have chest pain, patient can have chest pain, and a characteristic feature, patient may develop xanthomas. Xanthomas. Let me see if I do have the picture of xanthomas, guys. Just a second. Just a second. I think I have this picture in my, gallery. Yeah, I do have the pictures. You see, on the screen, you can see this collection of the fats. This is called as what, beta? Xanthomas. What is this? This is called as xanthomas, right? So this is very common. You can see in a routine day-to-day life when a person is coming to the hospital for a routine checkup. Yeah, so this is most commonly seen, right, in the person who are having atherosclerosis. So this is called as xanthomas. Another picture I would like to share with you guys is this picture, that I wanted to show you the picture of the vessels. I just had a, now you see. See, what is this? This was taken on an autopsy, where you can find that this was the normal diameter. This was the normal diameter of a vessel, but now you can see how much of the fat and the lipid accumulation is here. So now it has reduced to this size. This has reduced to this size. So all this yellowish color, is the accumulation of the fat and the lipid. Now you can see that there is a lot of, what you call it as, इसमें सारे के सारे में क्या देख सकते हैं बेटा, ये सारे वाला येलो 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 ये जो पड़ा हुआ है सारे का सारा क्या है, this is the accumulation of fat and the lipids, and it is obstructing, it is blocking the normal flow of the blood. So now, is this patient going to have dyspnea? Yes, this patient is going to have dyspnea. I hope I have made this concept very clear. Okay, so let's move further. So how you are going to do the investigation? So the first very investigation, what we are going to look is the lipid profile. What we are going to look is lipid profile. We are going to look for lipid profile, and in lipid profile we are going to have dyslipidemia, or let's say hyperlipidemia also, whatever you want to talk. Why I choose dyslipidemia? Because in books like Robbins or in Harrison, it is written dyslipidemia because all the lipids like LDL, VLDL, triglyceride, they are increasing, but HDL is reducing. So not every lipid is increasing, whereas HDL is reducing. That's why the term is called as dyslipidemia, or you can also remember hyperlipidemia. But point to be remembered over here that the HDL level is going to be on a lower side. This you have to remember. Second investigation you have to do is an ECG, right? Third investigation you have to check for the fasting blood sugar, random blood sugar, because hyperinsulinemia is another risk factor, or you have to check for the HbA1c. Another risk factor was CRP. So you have to look for the CRP. Probably you are going to find an increase in CRP, and might be there is possible that homocysteine levels are also increased. Homocysteine levels needs to be checked, right? Then you have to check for urine routine microscopy to look for any protein loss or not, right? Maybe there is some renal cause where you are losing the proteins and the lipids also, like in nephrotic and nephritic syndrome. So you have to look for this. A renal function test needs to be checked out, right? So now you are done with all the investigations, guys. So let's move further for the treatment. Before we move for further the treatment, quickly revise what we have discussed till now. We are going to discuss about the important aspects of the atherosclerosis, and in important aspects we know that what is Atherosclerosis, it is the accumulation of the fats and the lipids in the walls of the blood vessels. First of all, so there is collection of this. I have drawn this picture. Major risk factor is what beta? Coronary, it is the risk factor for the coronary artery diseases. Risk factor for atherosclerosis, one number: smoking, hypertension, diabetes, dyslipidemia, increased level of homocysteines, increased CRP, increased fibrogen, hyperinsulinemia, cocaine abuse and heroin abuse, and a positive family history of coronary artery disease. Right. Clinical features: patient will have shortness of breath or dyspnea with decrease in the exercise tolerance. Patient can have chest pain. Patient can have xanthomas. Right. So these all are the this one clinical features. Investigations beta. We are going to look for the first lipid profile. In lipid profile, we are going to get dyslipidemia, hyperlipidemia, and in ECG we will look for some changes. Then we are going to check for the fasting blood sugars, random blood sugars, HbA1c, CRP, homocysteine levels, urine routine microscopy, and renal function test. So this was the investigation part. Now let's look how you are going to treat. So first of all, what is the treatment? First of all, what is the treatment? We know that doing some exercise or doing some physical activity is actually going to burn out the extra fats. So first of all, lifestyle modification. Lifestyle modification. Lifestyle modification. Diet control or diet modification. We have to recommend a high fiber diet. High fiber diet, right? Or you have to recommend high omega 3 polyunsaturated fatty acid, polyunsaturated fatty acids. It is also called as what beta? It is also called as PUFA, right? Polyunsaturated fatty acids, which we have to recommend. Got my point? Okay. Then, my dear friend, I have told you lifestyle modification. In what type of lifestyle modification? I have told you that you have to, recommend a high fiber diet and exercise. Now, what type of exercise you are going to recommend the patient? Are you going to recommend the patient that go and join some, expensive gym and start carrying the weight? Do weightlifting? No, we are not going to do this thing. A simple light aerobic exercise is recommendable. Light aerobic exercise is recommended. Simple light aerobic exercise is recommended, right? Maybe it's like walking on the treadmill for 20-25 minutes in a day for at least 5 days in a week, or they can have a good soft sole shoes and they can do a brisk walk around the garden, right? Whatever is possible. So only thing is this light aerobic exercise. And now even the studies are showing that doing yoga for 30 minutes on daily basis for at least 5 days in a week is also recommended for the reduction of the for the reduction of the increased level of cholesterol or triglycerides or hyperlipidemia, right? This is also recommended. But do remember, light aerobic exercise is the recommendation. Okay. If all this doesn't work, then you have to go for a pharmacological treatment, and in pharmacological treatment you have to give the anti-lipid drugs or lipid lowering drugs. So lipid lowering drugs will include, like, first of all, statins. So you have to give statins, right? Now it depends that which kind of lipids has increased. If you find that in the lab report you do have you have an increase in LDL and you have that increased level of triglycerides, then what kind of statins you are going to recommend? So you are going to recommend like atorvastatin, atorvastatin, rosuvastatin, rosuvastatin, right? Simvastatin, simvastatin, right? Atorvastatin, rosuvastatin, simvastatin. Why I am saying that you are going to recommend this? In which cases, beta, our main these drugs are HMG coagulase reductase inhibitors. So what is their mechanism of action, or let's say what is their effect? So they are going to reduce the LDL levels and they are going to reduce the triglyceride levels. Triglycerides level, right? LDL and triglyceride levels are increased, right? So if you find that the HDL level is increased, is on a lower side and the triglyceride levels are on a higher side, so you have to give another category. This category belongs to lipoprotein lipase inhibitors, and drugs include like gemcitabine, gemcitabine, and how they are going to help us. They are going to help us basically by the reduction of what beta. They are going to reduce the they are going to reduce triglycerides triglycerides, and they also help in increasing the HDL levels. Then we have another category by the name of niacin, and the drug which is include is niaspan. Where we use this, where we find that the HDL level is on a lower side, so it helps in increasing the HDL, and it also helps in reducing the LDL. It also helps in reducing the LDL. And then we have cholesterol absorption inhibitors. The fourth category is called as cholesterol absorption inhibitor, and the drug which we use is ezetimibe. What drug beta? Ezetimibe. What does it does? It reduces the LDL. It reduces what beta? It reduces the LDL. So guys, this was all about atherosclerosis. Quickly revise all about atherosclerosis. Hanji, quickly revise. Let's quickly revise about atherosclerosis. So I am going to take the revision from the investigation part. The first investigation we are going to check is about the lipid profile. We are going to find dyslipidemia or hyperlipidemia. Right, then we are going to do an ECG. Now fasting blood sugar, RBS, HbA1c, CRP, homocysteine level, and urine protein microscopy needs to be done, and RFT needs to be checked. Treatment beta, first of all, lifestyle modification, exercise is recommended. What kind of exercise you will recommend? A light aerobic exercise. A high fiber diet is recommended. Then omega-3 fatty acid is recommended, right? Omega-3 polyunsaturated fatty acid is recommended. Then what is the treatment you are going to do? You are going to give the statins over here. Statins, depending upon the report, that where is the dyslipidemia and what kind of dyslipidemia is there. If you find abnormality in the LDL and triglyceride, you are going to recommend, like atorvastatin, rosuvastatin, simvastatin, right? And lovastatin is another drug. You can also write lovastatin. Lovastatin. So these drugs are going to reduce the LDL and going to reduce the triglycerides. Then you can recommend gemcitabine. Gemcitabine is what beta? It is the lipoprotein lipase inhibitor. What it is going to help us? It is going to reduce the triglyceride levels, and it is going to elevate or increase the HDL levels. Then we have a niacin group. Niaspaz is the drug. It is going to increase the HDL, and it is going to reduce the LDL. And ezetimibe is being recommended. What is ezetimibe? It is basically a cholesterol absorption inhibitor. So this is how we are going to approach to a case of atherosclerosis. So this was all about a quick review of the atherosclerosis. Hanji, any queries, any questions? Okay, so let's move to the next very important topic, a quick revision. I am talking, it's a comprehensive, revision. The detailed course is available upon the, Unacademy platform, the app, right? So the next topic is coronary artery diseases. So let's talk about the important topic, that is what beta? Coronary artery disease. Next, we are going to discuss about the coronary artery disease. Okay. Why does this coronary artery disease develops basically? What is the basic mechanism? The basic mechanism is this: it is due to the ischemia in the myocardium. It's because of what, beta? It's due to ischemia in the myocardium. In the myocardium. Now, there are two things. First of all, this ischemia is going to give a stable angina. What it is going to give? It is going to give a stable angina. It is going to give bit of what? Stable angina. What are the clinical features of the stable angina? Let's discuss about the clinical features of the stable angina. The first very important clinical feature of stable angina is chest discomfort, right? So the patient is going to have, first of all, chest discomfort. Chest discomfort, right? Then patient can have, chest pain, which radiates to the center of chest, radiates to the center of chest, arm, scapula, bilateral shoulders, and particularly this is towards the left arm, mainly towards the left arm, right? Bilateral shoulders. It can radiate towards jaw, then, and maybe up to umbilicus, sometimes maybe up to umbilicus, and maybe it is sometimes it is up to the umbilicus, right? Okay. Now, why is this called as stable angina? Why this is called as stable angina? This is the important feature. Why this is called as the stable angina? Hanji, why it is called as stable angina? Understand the concept. Those कि यहाँ पे stable angina का एक characteristic feature होता है, where we do have one characteristic feature, that this pain is relieved by taking rest or by taking nitrates, right? Pain relieves by taking rest. This is the important feature: by taking rest or by taking nitrates, or by taking nitrate. This is the important feature, right? Now, another characteristic feature of this is the important characteristic feature. So always keep this in mind, that the pain is getting relieved by taking nitrates or by taking rest. And another characteristic feature which I wanted to share with you is this, that this pain of a stable angina does not last for more than 10 minutes. Doesn't last for more than 10 minutes. If it is lasting for more than, let's say, 20 minutes or something, it is unstable angina and patient have a MI. Do remember this thing. So the characteristic feature, if the pain is subsiding or the pain patient is getting relieved within 10 minutes, generally the patient gets relieved within 3 to 4 minutes, but the maximum time is up to 10 minutes. Within 10 minutes after taking the nitrates or after sitting relaxed, the patient gets relief within 10 minutes. If it is not getting relief, then you have to suspect some kind of unstable angina or maybe a myocardial infarction. What is the most common cause of, this, what you call it as, most common cause of stable angina? So the most common cause, we know that we have just discussed about atherosclerosis, and in atherosclerosis we discussed that it is the most common cause of coronary artery diseases. And we know this thing, why there is a coronary artery disease, because there is a mismatch between the oxygen demand and the supply. Demand is high, supply is reduced. And why it is because in the vessels, in the coronaries, there is accumulation of fat and the lipids, which is not allowing the blood to get supplied properly to the cardiac tissues, right? So what is the most common cause? Hanji, most common cause is atherosclerosis. So the most common cause beta is atherosclerosis. A patient is presenting the doc sahab, I am having intermittent chest pain. What it is relieved by taking rest or by taking sorbitrate or nitroglycerin, I get relief. I would like to get investigated myself. So being a physician, what you are going to do the investigation? What kind of investigation you are going to do? So the best initial investigation. Hanji, let's talk about the investigations. The best initial investigation, best initial test we are going to do is ECG. Now, guys, suppose that the patient can show ECG changes at the time of ischemia, or at the time of when the oxygen is on a lower oxygen supply is on a lower side. But now the patient is presenting to you in a routine day, in a routine OPD. That time patient didn't had any symptoms, right? His coronary arteries were supplying adequate amount of oxygen. My question to you is this: is the ECG going to show you some changes or not? Obviously not. So in majority of the cases where we are expecting a stable angina, ECG is going to come normal. So if the ECG is going to come normal, then what is the next investigation? That the patient is telling, sir, I am having chest pain, maybe on exertion, maybe in a stressful event. As soon as I take rest or take nitrates, this is gone, this goes, right? Then what you are going to do? Obviously I told you that when he is in a stressful event or he is doing some physical activity, that time the demand of the oxygen will increase. Why not we induce the stress over here? So what we are going to do, we are going to do a stress test. Now how we are going to do the stress test? Are we going to say something to that patient, or we are going to tell some very bad news to that patient that he comes into a stress? No, we are not going to do that. We are simply going to say that, sir, relax, we do have a test which is called as what beta? TMT, treadmill test. So we make the patient to run upon the treadmill, and we know by doing a heavy physical activity, it is going to increase the demand of the oxygen. And then we note ECG upon the computer, and we can take the printout. So what is the characteristic feature upon the TMT which is going to tell the yes, this there is some problem? So the first very thing we are going to think is that there will be ST depression of 2 or more than 2 millimeter, 2 or more than 2 millimeter. ST depression will be noted over here. Second, my dear friend, let's say the patient is having some deformity with his knees, or he is not able to walk. Are you going to make the patient to run or walk up on the treadmill? No, we are not going to do that. Then what we are going to do? We are going to do a dobutamine stress echo. Dobutamine stress echocardiography. What we are going to do, beta? We are going to do a dobutamine stress echocardiography. So what we are going to see over here in the dobutamine stress echocardiography, we are going to give the IV dobutamine, and then we are going to do the echocardiography, and we are going to see the walls of the heart, how they are moving. To move the wall or to make a motion in the wall, we obviously need some of the oxygen. The ATP ADP cycle, the oxygen myocytes need some energy. But now if there is a stress which is induced, the supply is reduced but the demand of the oxygen is increased. So what it is going to lead? It is going to lead to hypokinesia. It is going to lead to hypokinesia. So hypokinesia of the cardiac walls will be present. Do remember this thing. But apart from this thing, we want to have a most accurate test. So most accurate test is what, beta? The most accurate test is angiography. The most accurate test is angiography. Apart from this, the fourth very important test we can do is cardiac imaging. We can do is cardiac imaging. What kind of cardiac imaging we can do? Obviously, we just did an echocardiography. So again, echocardiography can be done. Echocardiography. We can do a cardiac MRI. Cardiac MRI. We can do some radionuclide imaging, right? We can do what, beta? Radionuclide imaging can be done, right? Now, what kind of radionuclide imaging can we can do? First of all, we can do a ventriculography and a Muga scan. Ventriculography. We can do a second. It is called as what, beta? Muga scan, right? Another nuclear imaging we can do is thallium scan. Thallium scan can be performed. Thallium scan can be performed. So quickly revise what we have learned till now. The first very important thing that we learned over here, that coronary artery disease, basically why does it occurs? It occurs due to ischemia in the myocardium. First, patient can present with stable angina. Clinical features of stable angina are going to be, the chest discomfort, chest pain, which is going to radiate towards the center of the chest, arm, left arm particularly, scapula, bilateral shoulders, jaw, and maybe up to the umbilicus. This we are very clear. And this pain basically, or the symptoms, they get relieved by taking rest or by taking nitrate. And the characteristic feature of this, that the symptoms and the pain is basically up to maximum of 10 minutes. If it is beyond maximum 10 minutes, let's say it is 15-20 minutes, then it is not a stable angina, it is unstable angina, and you have to highly suspect a myocardial infarction. Most common cause of coronary artery disease is atherosclerosis, right? Investigations, best initial investigation is ECG, which is going to be a normal in majority of the cases, right? If it is going to be normal, then we are going to do stress tests like TMT. ST depression of 2 or more than 2 millimeter is seen, then the dobutamine stress echo. We are going to see for hypokinesia is going to be positive. Most accurate test is angiography, cardiac imaging. We have to do echocardiography, we have to do cardiac MRI, right? Then we can do some radionuclide imaging like ventriculography, Muga scan, or then we have to do a thallium scan, right? So this was a quick overview. Now, what is the treatment of a coronary artery disease, or what is the treatment for a stable angina? Hanji, first of all, we have to give nitrates to this patient. We have to give nitrates to this patient. In this nitrates, what we are going to do, that we are going to give like sorbitrate or nitroglycerin. Sorbitrate or nitroglycerin, right? Then we have to give statins. Statins, we have just discussed statins, right? Apart from this, we have to give drugs like aspirin, right? We have to give drugs like aspirin. Just a second, guys. We have to give aspirin, clopidogrel, aspirin, clopidogrel. We can give prasugrel. We can give prasugrel. We can give ticagrelor. Right? So these are the some of the drugs. If the patient is having a higher blood pressure, then we have to give antihypertensive drugs, like we have to give beta blockers, calcium channel blockers. So calcium channel blockers, I am writing CCB, calcium channel blockers. We have to give beta blockers. We have to give beta blockers. Right? Just a second, guys. Let me see what's in the chat room. Right? Okay. Then, my dear friend, we have to give ACE inhibitors. We have to give ACE inhibitors, right? Like ramipril captopril. So these are the drugs. Guys, these all are oral anticoagulants or oral antiplatelets, not anticoagulants, sorry, oral antiplatelets. These all are oral antiplatelets. Right? So this is the treatment. Right? Okay. Apart from this, then afterward the patient lands up into, I told you that the patient lands up into unstable angina if the pain is not subsiding, right, and the patient is having chest discomfort, pain and rest, and it has other features like chest pain is lasting for more than 10 minutes, right, and it is not relieving by taking nitrates or aspirin, right, and the chest pain has a recent onset, it's of recent in onset, and this chest pain has just started within the last 2 weeks, and the patient is in unstable angina, please do suspect that, right, and in ECG. Okay, I'm just going to tell you about the unstable angina also. Right. Guys, in recent, maybe in, NEET PG examination, there was a question about anticoagulant or antithrombolytics. So I'm just going to, quickly tell you about some anticoagulants. Anticoagulants, because we are talking about the coronary artery diseases. So, and, anticoagulants is the important thing. So first of all, let's look what are the anticoagulants. The anticoagulants are divided into two. One, anticoagulants are parental anticoagulants, and the other one are like oral anticoagulants. Parental includes like unfractionated heparin, fondaparinux, fondaparinux. Then we have enoxaparin, enoxaparin. Fourth one we do have vivelirudin, vivelirudin, right? So these all are given as parenteral, right? What are the oral anticoagulants? First of all, we can give rivaroxaban, rivaroxaban. We can give dabigatran, dabigatran. We can give apexaban, apexaban, and doxaban, apexaban, and doxaban. These are some of the anticoagulants, right? So this is the important, put a star mark over here. So when you revise, please do revise this thing. Metazelo, sir, what is the mechanism action of semi-fibrogel? Okay, so basically, beta, I am replying to your question. This is basically a lipoprotein lipase inhibitor. It is going to help us in elevating or increasing the high density lipoproteins, as well as it is going to lower down the triglyceride levels. Right? I hope I have sorted your query. Okay. So apart from this anticoagulants, another important thing that you have to keep it in mind is, guys, about the thrombolytic drugs. So drugs which are used as thrombolytics, do remember this thing. So thrombolytic drugs include Like, first commonly used drug is streptokinase. First commonly used is streptokinase. Then we use retipulase. Then we use retipulase, streptokinase, retipulase, tenecteplase, right? Then fourth one is recombinant RTPA, recombinant tissue plasminogen activator. So these are some of the drugs which needs to be always upon your fingertips. So quickly revise this. So anticoagulants and thrombolytics. Quickly revise this, guys. Then we proceed further. Okay. Now, adjoining to this, the next topic we are going to talk about the unstable angina. So let's talk about unstable angina. Unstable angina. Okay. So what is unstable angina? Those unstable angina, understand the concept over here, that it is also a chest discomfort or chest pain. So it is a chest discomfort. Patient can present with chest discomfort or chest pain and have three features. And have three features. Among all these three features, at least one of three should be positive. What I am going to talk about these three, among this one should be positive. So what are these three features? First of all, the patient can have chest pain. Patient can have chest pain which occurs at rest, which occurs at rest or with minimal physical exertion, with minimal physical exertion or activity. And time duration, as I just discussed in stable angina, that in the case of stable angina, this chest pain or chest discomfort, it gets sorted out, the patient gets relief within 10 minutes. This kind of chest pain in an unstable patient, do remember this thing, it is not going to get rid or it is not going to get relief within 10 minutes. It is going to last for more than 10 minutes. Do remember this thing, for more than 10 minutes. Do remember this thing. So you should be very smart to remember this thing, and you should be very smart to pick this clue in the MCQ. Only then you are going to have a right answer. So this is one. Second दोस्त यहाँ पे क्या हो सकता है, that this pain should be of recent onset. Pain of recent onset. Pain of recent onset means, pains of recent onset means acute pain, maybe up to within last, it started occurring within last 2 weeks, right? This is another criteria. And the third very important feature, it is of crescendo pattern. Pain occurs in a crescendo pattern. Means crescendo means beta increasing pattern. In crescendo pattern, pain increases in a crescendo pattern, right? Any three, I have told you guys, underline this, that any one should be positive among these three. And what are these three? We have discussed that the chest pain, that it occurs at rest with minimal physical exertion which is lasting more than 10 minutes. Pain should be of recent onset, it's of acute onset, which has started within last 2 weeks, or maybe just suddenly patient was sitting and started having chest pain. This is another case scenario. And this patient should have an crescendo pattern, means the pain is increasing and increasing. If any one of these three is present, do suspect an unstable angina. What you are going to suspect? An unstable angina. So what is the investigation you are going to do if the patient is presenting to you? The investigation you are going to do, first investigation is ECG, and on ECG what you are going to find, there is myocardial infarction. There is myocardial infarction. Now this myocardial infarction can be, of two types. One, it can be a ST elevation MI. ST elevation MI. It can be of N-STEMI. It can be of non-STEMI. It can be of non-STEMI. Right? So guys, this was all about the atherosclerosis, about the coronary artery disease. The next topic we will have a myocardial infarction. For that, I request all of you to please show your presence on the Unacademy platform or on the app. There we will discuss all these things in detail. So quickly revise about this thing. If some query or if some doubt is there, then please type me in the chat box. I would love to sort out your queries. Else we can start the next topic. Okay. So can we proceed to the next topic? Next topic we will discuss from the respiratory medicine, and the important topic we are going to discuss is about the interstitial lung diseases. So the next topic we are going to discuss is about from the respiratory medicine, and the next topic what we are going to discuss is about the ILD, that is interstitial lung diseases. Right. So guys, interstitial lung diseases we are going to discuss. Okay. So ILD basically beta, it's a group of more than 200 disorders which are characterized by, it is characterized, there are more than 200 type of ILD, you know this thing, right? Right. This is characterized by fibrosis and inflammation of lung parenchyma. It is characterized by fibrosis and the inflammation of the lung parenchyma or interstitium. Or interstitium. Do remember this thing. Right. Now what is this interstitium, guys? Understand the concept that suppose those, this is an alveoli. ये क्या है? एक alveoli है. This is another alveoli. This is another alveoli. Below to this we do have what beta? Below to this we do have a pulmonary capillary beds or the pulmonary capillary blood vessels. So you know the space between these two alveoli and the space between this, it is called as interstitium. It is the interstitium in the lung, and it is basically the region between the alveoli and the pulmonary capillaries. Now, this interstitium is having a variety of cell types. Like this cell types, what are the cell types this interstitium do have? This do have macrophages. क्या है बेटा यहाँ पे? Macrophages. There are fibroblasts. There are macrophages, fibroblasts, myofibroblasts. So myofibroblasts are there, right? And apart from this macrophages, fibroblasts, myofibroblasts, patient have matrix components like matrix components. कौन से मैट्रिक्स कंपोनेंट्स हो सकते हैं दोस्त? अंडरस्टैंड द कंसेप्ट. द पेशेंट कैन हैव कोलाजन, elastin and proteoglycans. So patient can have proteoglycans. So this all is included in this what you call it as interstitium, right? So guys, quickly revise, or if you are writing, then quickly write it down. Okay. So what basically happens, guys, I'm just going into a little bit of pathophysiology over here, how this ILD develops over here. Understand the concept that suppose that this is an alveoli. This is an alveoli. There it is an alveoli. Here it is an alveoli, right? I told you that there are fibroblasts over here. So what happens over here? There are interstitial fibroblasts. So these are the interstitial fibroblasts. I'm just drawing this. These are the interstitial. If I'm writing interstitial fibroblasts, this interstitial fibroblasts, they start producing the collagens. First of all. These collagens, they further produce more collagens. They produce more collagens. They further produce more collagens, and they also produce extracellular matrix. Extracellular matrix component. And they produce extracellular matrix component such that they start producing elastin and proteoglycans. They start producing elastin and proteoglycans. Now, my dear friend, they just not start producing the fibrosis. So due to this, there will be first of all fibrosis, but it doesn't stop with the fibrosis, but they also damage the pulmonary vasculature. See, I told you there are vessels. So first of all, they are damaging this, due to this fibroblast, they damage this parenchyma, and they also damage this pulmonary vasculatures. So they damage pulmonary vasculature. They damage the pulmonary vasculature and small airways. This damage will lead to what, beta? Now pulmonary vasculature is damaged, right? So there is fibrosis, and there is damage to the pulmonary vasculature and the small airways. That's why there is a diffuse, this will lead to a diffuse parenchymal disease. Diffuse parenchymal disease. There will be a diffuse parenchymal disease. To understand this thing, and it is also known as diffuse parenchymal disease. And these changes are basically irreversible. Once this parenchyma is diseased or it is damaged, changes become irreversible and it leads to abnormal gas exchange. This will lead to abnormal gas exchange and changes become irreversible. Abnormal gas exchange. Now guys, at your level, they expect you to know the classification of the ILDs. So the classification of the ILDs, let's talk about the classification. So the classification is basically divided into main two categories. One, ILD of a known cause, ILD of unknown cause. What beta? ILD of a known cause and ILD of unknown cause. So let's write down ILD. I'm just going to segregate this into two types. ILD of known cause, ILD of unknown cause. ILD of known cause and ILD of unknown cause. So let's talk about ILD of the known causes. Now ILD of known causes is further segregated into two things. One, it is because of the exposure or due to some systemic diseases. So let's talk about first ILD of known causes. It is again subdivided into two parts, right? The first very important part is because of exposure, and the second one because of systemic diseases. Because of the systemic diseases. Now again, my dear friend, exposure can be of two things. One, it can be due to some occupational related, or maybe it can be due to some treatment related. So exposure is further divided into two parts. One, it can be because of occupational occupational and second, it can be due to treatment related. It can be due to treatment related, right? Now what are the occupations which can actually cause this ILD? So the first very important occupation is exposure to silicosis or asbestosis. So silicosis and silica dust and asbestosis and asbestosis. This is the important thing. Whereas the treatment related, what are the treatment related? So the treatment related, like first of all, people who are undergoing their treatment for cancer, for particularly radiation, right? A very important drug, my dear friend, anti-arrhythmic drug, most commonly anti-arrhythmic drug. This is the, I am putting the star mark over here because this question is the most common question which has been asked on regular basis, and this drug is basically used in day-to-day routine practice. So what is this drug? This drug is called as amiodarone. Amiodarone is the drug. Apart from amiodarone, there is another common drug which is also used in regular cases, in a case of UTI or in nephrology and in urology, that is nitrofuranation, not nation, nitrofurantoin, right? Then methotrexate, methotrexate. So these are some of the treatment related things which are responsible to cause ILDs. These are responsible to cause some of the ILDs. Okay. These are some of the drugs which are responsible to cause ILDs. Okay, guys, I am taking this systemic diseases on a lower side because of less space availability. I hope you understand, right? So systemic diseases, right? Systemic diseases. What are the systemic diseases which come under the ILD of known cause? So the first very systemic disease we have is connective tissue disorders, connective tissue disorders, rheumatoid arthritis, scleroderma, scleroderma, polymyositis, polymyositis, then dermatomyositosis, dermatomyositis. So connective tissue disorder, rheumatoid arthritis, scleroderma, polymyositis, and dermatomyositis. Dermatomyositis, right? So these all are the systemic diseases which are associated with a case of ILD of known cause. Do remember this thing. Apart from this, this is one. Apart from this, my dear friend, systemic diseases like this was part A. Then we do have granulomatous diseases with vasculitis, granulomatous disease with vasculitis, right? Then granulomatous with cholangitis, granulomatous with polyangiitis means there is inflammation of the vessels, right? And Churg-Strauss syndrome is also responsible to cause ILDs, CS syndrome, right? Churg-Strauss syndrome. So guys, quickly revise about the ILDs of classification of the ILDs. We have discussed this classification into two parts. One ILD of known cause, second ILD of unknown cause. In known causes, we have segregated this in two parts. One on exposure related and one we have some systemic disease related. Exposure we segregated into two parts. One is occupational related and one is treatment related. Occupation, exposure to silica dust or asbestosis, right? So silicosis and asbestosis. Treatment related, my dear, radiation, chemotherapies, right? Amiodarone, nitrofurantoin, and methotrexate. Systemic diseases like connective tissue disorder, rheumatoid arthritis, scleroderma, polymyositis, and dermatomyositis, right? Then we have granulomatous diseases with vasculitis or granulomatous with polyangiitis or Churg-Strauss syndrome, right? Okay, ji. Now we have ILD of unknown cause. What do we have? ILD of unknown causes. So I'm just writing over here. I'm just bringing this line below, guys, so that we can make a table carefully. I'm just bringing this down. I'm writing over here ILD of unknown causes. ILD of unknown causes. ILD of unknown causes. Now, it can further segregated into two parts. One is idiopathic interstitial pneumonias and the other part is other causes. So let's segregate this into another two parts. One is idiopathic. Idiopathic का मतलब कि पता नहीं यार क्यों हो रहा है, पर हो रहा है. क्या हो रहा है? Interstitial pneumonias. Idiopathic interstitial pneumonias, and the other one is other causes. Other causes, right? The first one is idiopathic pulmonary, idiopathic interstitial pneumonia. The first very important cause is it is segregated again into two parts. The first one is idiopathic pulmonary fibrosis, IPF. It is called as idiopathic pulmonary fibrosis, IPF. And we do have causes for idiopathic interstitial pneumonias. Other causes is basically like cryptogenic organizing pneumonias, COP it is written, right? Non-specific interstitial pneumonias, NSIP pattern, non-specific interstitial pneumonias. Then we do have discommutative interstitial pneumonias, BIP, discommutative interstitial pneumonias, right? Then we have acute interstitial pneumonias, AIP, right? Then lymphocytic interstitial pneumonias, LIP, right? Lymphocytic interstitial pneumonias. And apart from this, we have respiratory bronchiolitis associated respiratory bronchiolitis. Respiratory bronchiolitis associated interstitial lung diseases. IL, respiratory bronchiolitis associated interstitial lung diseases. So what are the causes of idiopathic interstitial pneumonias? One, it is idiopathic pulmonary fibrosis. On the other hand, we have causes like cryptogenic organizing pneumonias, non-specific interstitial pneumonias, discommutative interstitial pneumonias, right? Acute interstitial pneumonias. Then we do have lymphocytic interstitial pneumonias and respiratory bronchiolitis associated interstitial pneumonias, right? Okay, ji. Right. Then in some other causes, we have like pulmonary alveolar proteinosis, pulmonary alveolar proteinosis, pulmonary alveolar proteinosis, Langerhans cell histiocytosis, Langerhans cell histiocytosis, histiocytosis. We have lymphangioliomyomatosis, leiomyomatosis, lymphangioliomyomatosis, right? So these all are the some of the other causes of ILDs, right? So quickly revise about the ILDs of unknown cause. So ILDs of unknown cause are segregated into two parts. One is idiopathic interstitial pneumonias and others. Idiopathic interstitial pneumonias are of two types. One is idiopathic pulmonary fibrosis. On the other hand, we have cryptogenic organizing pneumonias, non-specific interstitial pneumonias, discommutative interstitial pneumonias, acute interstitial pneumonias, lymphocytic interstitial pneumonias, respiratory bronchiolitis associated interstitial lung diseases. On the other hand, we have pulmonary alveolar proteinosis, Langerhans cell histiocytosis, lymphangioliomyomatosis. Guys, from there is a mixture of, apart from this, I am talking about the known cause and unknown cause. There are three diseases which come under the category of both, maybe unknown, maybe a known cause. So for known and unknown causes, right, where we do have a mixture of these things, there are three diseases, right? Not three, basically two diseases. One is sarcoidosis and hypersensitivity pneumonitis. Hypersensitivity pneumonitis or pneumonia. Hypersensitivity pneumonia. Right? Then you should have this knowledge in your mind that they can ask you something very, very important, that what are the ILDs which are smoking related ILDs. Smoking related ILDs, very important point. They love to ask this question. So smoking related ILDs, smoking related interstitial lung diseases. So the smoking related ILDs include like respiratory bronchiolitis, associated interstitial lung diseases, RBILDs. Then you have the second one, that is desquamating interstitial pneumonias, DIP. Desquamating interstitial pneumonias. These are the two which are smoking related ILDs: respiratory bronchiolitis, interstitial lung diseases, and desquamating interstitial pneumonias. Apart from this, guys, let's jump to the clinical features now. So what are the clinical features? We know basically that there is a diffuse parenchymal damage, right? We know this thing. And from the picture, where is the picture? Hanji, there is the picture. I told you there is interstitial fibrosis. So if there is beta interstitial fibrosis, यहाँ पे सारे का सारा क्या बन गया? This is the fibrosis in brown color. I am making this fibrosis, 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 fibrosis is there, and a little bit of inflammation is also there. Understand the concept, and the clinical features are going to be automatically in front of you. Now, if there is fibrosis, the alveoli is not going to expand properly. So if the alveoli is not going to expand properly, what is going to happen? The oxygen which was supposed to come over here into the alveoli, and then we know it is going to get dissolved into the pulmonary capillaries, and they carry the oxygenated blood. But now, because there is fibrosis don't allow the alveoli to expand properly. It is restricting. So another feature, that it is a restrictive kind of lung disease. It is restricting the alveoli to expand properly, or it is restricting the lung parenchyma to expand properly. So oxygen is not going to get diffused into the pulmonary capillaries, and hence there will be lack of oxygen. So if there is a lack of oxygen, the heart is not going to receive adequate amount of oxygen, but we need more oxygen. So there is a mismatch of demand and supply. You can say this also, right? And we know that when we need oxygen is not there. What is the clinical feature? First very clinical feature is this, that my dear friend, that the patient is going to have dyspnea, right? So the patient is going to have shortness of breath, or first of all, patient is going to have dyspnea, right? Now, this dyspnea basically can be of acute, subacute, or what you call it as, or chronic type, right? Dyspnea, I repeat, it can be of acute, subacute, or of chronic, depending upon what kind of classification the patient falls under. Whether it is ILD of non-cause, and if it is of non-cause, whether the patient is having acute history of drug use like amiodarone, he is undergoing some radiation, or maybe the patient has developed some systemic disease, or on a prolonged use, like the patient is getting exposure to silica dust or something like this thing, right? So it depends basically that the patient is presenting to you in a acute phase or in in a chronic phase. So just looking at the history, or just talking to the patient and digging out the history, you can actually tell whether it is a prolonged ILD or it is of recent type of ILD, right? Okay. Second very important clinical feature, the patient is going to have beta kya? Cough, right? Right. Now this cough, why the cough is there? Remember this thing, whenever there is inflammation or whenever there is restriction of the alveoli or fibrosis, there are J receptor, juxta-alveolar receptors. Due to this inflammation and due to this non-expansion of the alveoli, these J receptors, they get stimulated, and we know that these juxta-alveolar receptors are responsible to cause cough. Do remember this thing. Now this cough can be very severe, right? Particularly in a case of interstitial pulmonary fibrosis and in a case of sarcoidosis. Then the third very important feature, the patient is going to have chest pain. The patient is going to have chest pain and pleurisy. Right? Why there is? Remember chest pain, pleurisy, inflammation, and particularly over here, कहाँ गए हमारे? कहाँ गए? Yes, we have discussed about some of the vasculitis over here. We have discussed about the vasculitis and the collagen vascular diseases. So due to this inflammation, they give a inflammation give rise to pain, right? This gives inflammation to pain. That's why the patient is having chest pain and pleurisy. Another important feature of this, when you're going to do the physical examination, that in approximately 80% of the people, they are going to have clubbing. The 80% of the people are going to have clubbing. I know that when we had a, in the starting, we had a respiratory session. I have explained to you the mechanism of clubbing. What happens because of hypoxemia, the peripheries, they don't receive adequate amount of oxygen, and there is a, release of growth hormone, and because of this release of growth hormone, there is new angiogenesis under the nail beds, and this gives the formation of clubbing. Do remember, clubbing is the important feature. So when you are going to revise, do remember to revise the causes of clubbing. In clubbing, 80% of the people, they do have clubbing in interstitial lung diseases, right? Okay. So guys, fifth feature, when you are going to do the auscultation, what kind of feature you are going to hear? What kind of sound you are going to hear? You are going to find a creps. First of all, do remember this thing. And the characteristic feature of this crepe, they are called as Velcro crepes. Velcro crepes. Now the summers are going on. Majority of we people wear these sandals and with the Velcro, right? Like, Velcro. So that sound is called Velcro. Velcro. I don't have Velcro nearby. Otherwise, I would have shown you, right? Velcro crepes are there, and this is basically inspiratory crackles. When the patient is inspiring, you start hearing, crepes, and this is called as Velcro crepes. Okay. Guys, I told you that you can tell the ILD according to the time duration, whether it is acute, whether it is subacute, whether it is of chronic type. So quickly revise the duration. So ILD by duration of symptoms, by duration of symptoms, duration of symptoms, ILD by duration of symptoms. So first of all, we have acute type of ILD, which comes from days to weeks, right? So just a second, guys, let me have a sip of water. Right, ILD by duration of symptoms. First of all, we have is acute ILDs, where we see from days to duration. What are the ILDs which are responsible to come in a very quick stage? First of all is acute interstitial pneumonias. One thing, acute है बेटा, नाम ही acute है. Then is acute pneumonitis. Acute pneumonitis from collagen vascular diseases, from collagen vascular disease, particularly that of SLE. Particularly beta कौन सा? Systemic lupus erythematosus. Do remember, shortness of breath will be there and pleurisy was there. Pleuritic chest pain is the feature over here in SLE. Then we have cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia, right? Then drugs can cause acute type drugs we have just discussed, like amiodarone, methotrexate, nitrofurantoin, or even radiation. They can cause acute type of ILD. Then we do have hypersensitivity pneumonitis. Hypersensitivity pneumonitis. Hypersensitivity pneumonitis, right? So these are some of the causes of acute type. Quickly revise, guys, acute type of ILD, then we proceed further. Then we have what you call it as subacute type of ILDs, which comes from days to weeks, right? Oh, sorry, from weeks to months, not days to weeks, from weeks to months, from weeks to months. So like it can be again collagen vascular diseases, collagen vascular disease associated ILD, collagen vascular disease associated ILD. We do have cryptogenic organizing pneumonia, right? Then again some drugs, the same drugs I just discussed right now, right? Then we have subacute hypersensitivity pneumonitis, subacute hypersensitivity pneumonitis. Hypersensitivity pneumonitis, right? Then apart from this, guys, so these were all about the subacute cases. The last one we do have is chronic type, where the patient presents from months to years. So the chronic ILDs or chronic presentation, where the patient, it takes months to years to develop, right? The first one is idiopathic pulmonary fibrosis, IPF, idiopathic pulmonary fibrosis, right? Non-specific interstitial pneumonias, non-specific interstitial pneumonias, right? Then occupation related like silicosis, occupation related lung diseases like silicosis, asbestosis, silicosis, asbestosis, right? Then we have collagen vascular diseases, collagen vascular diseases, ILD, right? So these all are some of the causes of chronic type of ILDs you have to remember, right? So IPF and SIP pattern, occupation related like silicosis, asbestosis, collagen vascular diseases. So guys, this was all about the ILDs. Rest in the detailed class, we will discuss in detail the pathophysiology, the mechanism, the investigation, the treatment, the prognosis we are going to discuss. So I hope that you have enjoyed this class. A quick review of the cardiology we have discussed about atherosclerosis, we have discussed about stable and unstable angina, right? Then we switch to this ILDs. So these are the important topic, guys. Trust me, guys. You expect at least one or two questions always in any type of examination, either it is INICET, either it is NEET PG or FMG examination. So guys, I wish you a great day ahead, and I expect that you are going to revise this again and again. Only this fundamental of revision is going to give you the success. So guys, thank you very much, and I wish you a great day ahead. We'll see you in the next class. Thank you. Take care.